Welcome to the Dusty Muffins, where menopause meets sisterhood and strength. We're three menopause specialists coming together to laugh, share, and empower you through the wild ride of menopause and perimenopause. Whether you're curious, confused, or just looking for real talk, you're in the right place. We're here to answer your burning questions, educate, and advocate, all with a dash of humor and a lot of heart. So pull up your chair and join the conversation. Before we dive in, please remember, while we're doctors, we're not your doctors. This podcast is for educational purposes only and is not a substitute for medical advice. We encourage you to partner with your own medical clinician to address your unique health needs. This is the Dusty Muffins.
All right, everyone. Welcome, whatever time zone you're in, from wherever it is that you are listening to us. Today's episode is going to be about perimenopause and menopause myths, busting myths and perimenopause and menopause fact versus fiction. I am Dr. Rebbecca Hertel. I'm a board-certified osteopathic family medicine physician and a certified menopause practitioner, and I'm joined by my other two beautiful colleagues here.
I'm Aoife O'Sullivan, a board-certified family physician and Menopause Society certified practitioner in Portland, Oregon.
Welcome. I'm Dr. Christine Hart Kress. I am a board-certified women's health nurse practitioner and a Menopause Society certified practitioner, and I am over here in Northern Virginia.
Awesome. So today we have all of these fun, I would say common, right? Like common myths that we usually hear from either our women or maybe our Instagram followers. Mm-hmm. That we're going to bust all of these for you, and hopefully in a fun little way, and give you all a lot of clarity than to go storm your clinician's office and say, no, I have it right here. Because we heard it right on the Muffins podcast here.
And they're like, who are the Muffins? I want everybody to know who the
Not
Muffins
just Muffins.
are.
That's right.
Dusty Muffins.
The Dusty Muffins. Because one of those myths, we're going to try and prevent that from happening.
Oh, and you know what? It's not just women out in the community or men who have heard these myths. I mean, these are things that we hear every day that clinicians have said to our patients. So everyone needs this information.
I agree.
Yes.
Let's start out with talking about the Dusty Muffin. You know, let's talk about that one.
Because, well, I mean, I don't love it. That's the whole point.
Well, right. I mean, I share a lot. My muffin was real dusty, and she hurt like a Dickens until I got her fixed up. But I went to go pick up my my estrase vaginal cream, and the pharmacist calls my name and brings me over to the little secret window, and she's like, I just need to tell you that you can't have all of this. I said, have all of what? She's like, well, you have vaginal cream and you have estradiol gel. And that is way too many hormones. And you're going to have cancer if you take them all. I was like, hold up, wait a minute. Man, the whole pharmacy, and it's a military pharmacy, so there were some 50 of us spending the day at the pharmacy. They all learned all about vaginal estrogen and how it is absolutely safe to take vaginal estrogen, which works locally on the tissues, with systemic estrogen. And actually, we don't even see, maybe if you used a loading dose of vaginal estrogen, you'll see a slight bump in your estradiol level, but otherwise we don't see that. And so, and that should be part of our nursing home prevention plan, because the second largest receptor site for hormones is everything from the pubic bone to the tailbone, and she is missing her some estrogen. And not only will you have dryness or pain with intercourse, but we'll see people come into the clinic with, I think I have a yeast infection, and we culture it and it's normal. Or I think I have a UTI and we culture it and it's normal. And it is just the vulva, the vagina, and the bladder screaming, please put some cream on me. So I like, so now if you use it, your muffin won't be dusty and everything will work well again.
That's right. And I feel like, another little area that that women often don't tell you about either, that can get irritated, is what we call the perineum. Everybody else is it's that little taint area. So it's between the anus to where the vulva or your lips are, and that area in between can get really itchy and irritated. And most of the women are like, it's hemorrhoids. They're like, but I don't have hemorrhoids. I'm like, no, put your vaginal estrogen cream there. And then they're like, oh my God, it went away. I'm like, I know. So, that area too. So, from your, like you said, your pubic bone all the way to your little booty hole,
right?
You want to put the vaginal estrogen, just slather that.
And just
to,
you brought up hemorrhoids, but I have women who tell me that their hemorrhoids improve when I put them on vaginal estrogen. So, those hemorrhoids are made up of connective tissue, and the veins inside them, they have walls which are made of connective tissue. And so, of course, when I think about it, it makes sense how you can lose those structures and everything can get weak and collapse downwards. So it's just that no one's ever taught me that vaginal estrogen could improve hemorrhoids, but I hear it from my patients.
And then when you're done putting your vaginal estrogen cream in your nether region, go ahead, and it's a little like zinc oxide. So
wash your hands first, ladies.
Yeah, wash your hands first.
Don't get crazy like I did. And I was like, I go and I put all this vaginal estrogen cream on my face, because the same skin in your vulva vagina is on your face. And then I was like rubbing it in, like it doesn't rub in. So just a little dab will do you.
Yeah, a little dab
will do you. Moisturizer. Put it in. I mean, you could spend the expensive money on the $60 little bottle, or you can just ask your clinician to give you 2 tubes, and one for the outside, one for the inside, and then you have enough left over for your face.
We'll go into this in another episode, genital urinary syndrome and menopause, but just to quickly say, what happens is when we lose our vaginal estrogen down around the pelvis, it has a massive effect on the collagen and elastin production in those tissues. And we start to, instead of having nice plump tissues, they get thinner. The blood supply is not as good. Those cells are supposed to make glycogen, which feeds our microbiome. And so our microbiome dies off. Our tissues are supposed to be really acidic down around the vagina and the vulva, and they get less acidic. So your microbiome is dying off, your tissues are thin, the blood supply is not as good, you have no collagen or elastin, and everything is collapsing down and has a very poor blood supply and no lubrication. And so when you give those tissues back the estrogen, you get your microbiome back. Those tissues are nice and plump. They have a good blood supply, lots of collagen and elastin, and you have your 30-year-old vagina and vulva back with sensation in those tissues and comfortable sex.
I do hear some women, and I think it really is kind of dependent on how long they've been without, say that as we're starting therapy, that it makes it feel a little worse before it feels better. It should never feel terrible, but you may feel that. And then, you can be as old, like put your mom, put your grandmother, have them go get it, because little old ladies land in the emergency room with altered mental status changes, and all it is a urinary tract infection that ascended into the bloodstream. It's the number. When I worked in the hospital, we saw it all the time.
Oh, yeah. See it all the time. They start talking wacky, acting wacky, and I'm like, let's check a urine on you.
Anyway, we digress. What's another one?
In perimenopause, you don't need contraception.
Oh,
I love
boy.
this one, because if you have sperm in your life and you are not in menopause, you can get pregnant.
Yes.
So you need
Surprise.
Yes. Hello. Nobody wants that unless you want that at 45, 48, 50. If you are still cycling, I don't care if you haven't cycled for 6 months, because that egg's going to go out and meet some sperm.
Yeah, it can even make you more regular, right? Sometimes your periods have been really irregular, and we start someone on hormones and it regulates their period, probably increasing their chances of getting pregnant, really.
And
so those PCOS patients who are anovulatory, and PCOS is from low progesterone. I have 2 pregnancies on 10 days of progesterone.
Wow.
So,
yeah.
Low sperm.
Yeah. So you
Uh-huh.
need it. You definitely need it. Now, do you have to be on medication to prevent pregnancy? No, you all are grown ass women. If you don't want to be on a medicine or an IUD or an implant or whatever, then you need to practice safe sex, guys. I mean, I can't, we all know how that works, right?
You can use a
So,
condom and spermicide.
condom.
It can be as simple as that.
Make them
That's
get a
right.
But
That's right.
vasectomy. Because
or a
let me tell
vasectomy
you,
is my favorite.
So easy.
when I ask, women, because hormone therapy isn't going to prevent pregnancy, when I ask them, what's your birth control? And they're like, oh, nothing. I'm like, nothing? They're like, my husband has vasectomy. I'm like, rolling up my sleeves. All righty.
Let's go.
Get you fixed.
Because they'll be fine with a bag of peas and a couple days.
The IUD can be a good option.
Mm-hmm.
That's a progestin covered intrauterine device, and it can stay in there for over 5 years now.
Mm-hmm.
But we can also use that to protect the uterus from the estrogen that we're giving you. And then if you do need any progesterone on top of that, because progesterone can be very helpful for some women, it is safe to take it on top of having the IUD in place. So that's a great option too.
Right, because the IUD is local, correct? It does not go systemic. And so that's something that people get really confused on, and women get really confused on. And I'm like, no, that just changes the cervical mucus, changes the environment that sperm are like, they go in there and they're like, nah, I'm out. I'm out. I don't want to play up in this uterus. So,
yeah.
I think another one that made me think of it when you said that, Aoife, was another myth. I don't have a uterus. I can't have progesterone. And
all the time.
although you don't have to have it, because progesterone is to protect the uterus, the thickening of the lining from the estrogen, and protect the uterus from endometrial cancer, you still have progesterone receptor sites. That progesterone works on the GABA receptors in the brain and promotes relaxation, helps with mood, and helps with sleep. You absolutely can have progesterone if you don't have a uterus. Do you need it? No. Do you like it? Many women do.
And some women do need it, right? And to that effect, the other thing is the banking back off of that is and some clinicians don't understand that either. If you have a hysterectomy, why is your provider have you on progesterone? You don't need it. I've heard that so many times. And in the same breath, I have heard someone equal micronized progesterone, which is menopausal hormone dosing, and comparing it to the progesterone only pill.
Yeah.
No,
synthetic.
The progesterone only, the micronized progesterone is not going to be contraception. You can get pregnant with that. Progesterone only pill, the mini pill, is contraception. So they are not the same thing. They're synthetically different.
And one of the things that we see the most initially in perimenopause, I would say, is women coming in saying they have anxiety, either worsening anxiety or new anxiety, and difficulty getting to sleep. And they're so related to that lack of progesterone. When we were talking about our reproductive cycle and how we got those waves of estrogen and progesterone, and often one of the first things to drop during perimenopause are our progesterone levels. And that like Christine said, has such an effect on the brain. And so you might really not have anything else going on perimenopause wise, but you've got this anxiety and sleep, and maybe all you need is a little micronized progesterone at bedtime to help you with that. That's why this is so nuanced. That was a good one, Rebbecca.
We love
it. Thanks. I think it's so many questions surrounding that.
Yeah.
So, okay. What else?
What else do you have on I get a lot of patients coming to me saying they've already talked to their own doc about starting hormones, and their doctor has said, you're still having periods. We do not treat women who are having periods with hormone therapy. That's a big one I get, which is absolutely not true, right? Yeah, not true. Absolutely. It shows a lack of understanding really of what's going on. And you can't really blame any clinicians for that because we didn't get trained in it. But if you're listening to our podcast now, you understand the underlying issue that's going on with your hormones and how it makes sense that you can still have your periods but not have your hormones like you used to.
Yep, absolutely. I just had a patient not that long ago that said the same thing. And it wasn't just, it was, you're still oh, you're not there yet, so you can't have it. But this poor woman could not go to the bathroom and use tissue paper because she had such awful vaginal dryness and was told just some lubrication. I mean, so you can imagine that her intimacy and sex life with her partner is zero if you can't even clean yourself after you pee. And because these women, and it varies with everyone, but that's, I'm sorry. So not even vaginal estrogen. And it's unacceptable.
It's heartbreaking. Yeah.
And heartbreaking. Yep.
So here's another one. Menopause only affects older women. And, while it's true that, average age of menopause is sometimes you hear 51, sometimes you hear 52 in the United States. 90% of women have their final menstrual period between 45 and 55, but 5% of women will go through menopause before age 45. And 1%, that's called early menopause, and about 1% will go through menopause, have a final menstrual period before the age of 40. And so any symptoms that you're having that you didn't have, but now you are in your, somewhere in your 30s. And I have heard of women who go through premature ovarian, have premature ovarian insufficiency or have their final menstrual period even as young as their 20s. So if it doesn't feel right, most likely it's from your hormones, which can be quite erratic as the ovaries are downshifting and going into retirement.
Trust your gut.
Yep. Trust it. And you should have that conversation with your clinician. If they look at you and you're like, I'm having hot flashes and night sweats and I've missed my period, and, rule out that you're pregnant, of course, but that is not off the table. We see it. I've seen it. I've diagnosed within this last year, at least a handful, I'd say two for sure that come to my head, and some that had come to me with that prior diagnosis. So, it's there. It's there. You have to listen.
The patients I've seen who come to me, knowing what's going on with them, have already seen a doctor and have been told, oh, you've gone into early menopause, or you have premature ovarian insufficiency.
And
see ya.
And then see you later. You'll be just fine.
Oh my
you
God.
Don't need that.
And we have
Aren't you
so much
lucky?
we have so much evidence that shows these women have an accelerated rate of cardiovascular disease, and and dementia, myth. Right? So just so dangerous that we don't know this information. So really important, if you're listening to this, spread the word, tell your friends, talk to your family, because everyone needs this information.
So here's one I'm going to throw to each of you and tell me what you think. As far as a mythy kind of question, all women need hormone therapy. Thoughts?
I know.
They all need vaginal estrogen.
What do you think?
I've probably never met a woman who doesn't need vaginal estrogen.
Yeah,
if you ask her.
Do they all need it or do they all want it?
No, I'm going to say need. I'm going to just be like the evangelist of hormone therapy. All women need hormone therapy. Because some women, you see on social media, some women who are not providers, right, are very passionate about all women need hormone therapy. So what would you say to a woman who came to you and said, I hear I have to have it?
I would say I would just still go back to just the normal principles in medicine. You treat every person separately. Each case is very nuanced, and that's between her and her clinician. And I don't think I would ever paint with a broad brush like that. I think it's dangerous. It can send the wrong message. I've met women who are in their 80s, and I have bone density scans on them. They have no osteoporosis, no osteopenia. They are as fit as a fiddle. Their muscle, they have loads of healthy muscle. So other things are important as well. Lifestyle, avoiding alcohol, exercising, how much sleep you get, stress, all those are important. So I would say, no, I would never say all women need hormones. I would say just back to basic principles, treat each woman as a
Right.
unique case.
Yep. I would go back to the same thing, the evidence base, where you know, because they do come to you and say, listen, I want to be proactive. I heard that, you know, we need this. And I think you, with an, you know, as unbiased eye as you can, even though it's what we do, we give them all the data that we have and we go through the risks and the benefits. And, you know, and then I just tell them that this is ultimately your decision. And we also aren't married to anything. Whatever we stop, we can, you know, start. Whatever we start, we can stop. We can change. We cannot. You can go. You can come back to me later if you so choose. And so I think that's also an empowering conversation to have with our women, that this is your decision. Let me give you all of the tools and information that you need and the data to support that. Let's go over your risks and your benefits. And then this is ultimately a decision that you can make, and I can guide you in the best way I know how.
Yeah, this could probably be somewhere along the line of a knock knock joke, which I'm not about to go with a knock knock joke, but you know,
is it funny?
No, because I am not. My husband says I'm not funny, but I think I am sometimes. But you know, somewhere along the lines of, I'll have to think of one. Stay tuned. I'll find one for another episode. But somewhere along the line of, now my perimenopause brain is gonna kick in and I'm gonna freaking forget what I was gonna say. See, you asked me too many questions.
I know. Sorry. It's like, you know, those little pew 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 pew. Like it just like fire.
Oh man, it was gonna be. Oh, this is it. I remember. See, that is brain. That is perimenopause.
That's brain fog, everyone.
In thing. I think when you're talking about the empowerment, I think for women, when they, how do you know that you have a true menopause expert? Someone who's willing to let you take the reins, and they are just your guide, because. Yeah. In true midlife menopause care with shared decision making, like you talked about, Rebbecca, about giving all of the information. I mean, I have patients. I mean, like the decision is yours. Like, I just had a patient who went to a provider and they said the only hormone therapy you can have is the combi patch. There is no other choices. That is not a menopause practitioner. They are not. They know nothing about what they're doing. No, because you're going to bleed on that. By the by,
right? Oh my, yeah. We'll get into that.
So that just made me think about that. But we'll come up with a knock knock joke. Yeah, you have one. But but what you said, Rebbecca, all of that's what a partnership with a certified menopause practitioner is.
But exactly. And why I love it. That's why I love it. It's so fun. That part. Like, hey, what do you want to do? What do you think? What do you want to do? I don't know. You want a little list? Try this, try
that. Because it's all individually, individually tailored. All right. Wait, someone else.
We take risks again.
How about, I'm going to keep us on track. How about you have an underlying increased risk of blood clot, or you've had a blood clot in the past, you cannot have hormones.
Oh,
I'll start that off. So we have very good information that shows that when you take estrogen by mouth, and I'm talking about combined equine estrogen because honestly, there are studies now showing that estradiol may not have the same effect, but let's just put it all under one umbrella. Estrogen by mouth is metabolized by the liver. It's called first pass metabolism, and it does change your clotting factors. It increases your baseline risk of stroke or clot. So if I have a genetic disorder, let's say factor V Leiden deficiency, and my baseline risk of having a clot over my lifetime is 5%, and I take oral estrogen, I might increase that risk to 15%, So what we do is we avoid oral estrogen and we give it through the skin. It's called transdermal. You can do it with a patch or a spray or a gel, and that goes through the skin and directly into the bloodstream, and it bypasses first pass metabolism. There are no randomized control trials on this, which is always our gold standard, but we have tons of excellent observational information. And as a profession, I think we're all in agreement that transdermal estrogen does not increase your baseline risk of clot. So if my risk is 5% before I stick that patch on, and I stick the patch on, it stays at 5%. And all of us can have a clot in our lifetime for what seems like absolutely no reason. I've had clots in my arm for absolutely no reason. So that risk is there, and you have to understand that when you start any medication, that we all have risks, and that these things happen sometimes. And what you just want to make sure is you're comfortable in your knowledge of hormones, and you're not worried that was what caused that.
Yeah, and I think too, how did that, when women come and they've had a blood clot, the first thing I always ask is, was it provoked or unprovoked? Because unprovoked is much more concerning. You're just running around being you and you get a blood clot. That's much more concerning. And that's where your docs are doing those hematology workups to look for blood clotting disorders. And then the other thing that where if it's provoked, like you had an IV, for example, I would still start someone on a transdermal estrogen, because we know from the Esther study that, it was oral, not transdermal estrogen that had a 4-fold increased risk of blood clots. And so, I think that women need to know that there are options for them, even if they, have some complicated cases. And then the other two things I would say about that is I always ask, how did you do on birth control pills? And how did you do when you were pregnant? Because that's much higher levels of estrogen than giving you some replacement. And then every time I think about, is it contraindicated? I think you're my voice. Is the treatment of X, whatever your medical condition, is the treatment removing your ovaries? If it's not, you can probably have hormone therapy.
Yeah, it's really important because it can be very scary. And again, are we also counseling women when they're pregnant? And when we first put women on,
we never say a word
pills?
to them. No.
Do we talk about their clot risk?
No, you can buy the birth control pill over the counter now, and no one talks to you about your increase. It's amazing the mental gymnastics that we go through with hormone therapy.
Yeah, yeah. So I think we hit some of these just to keep us on, because sometimes we digress a little bit.
Sometimes,
sometimes every time, but it's fun. It's fun like that. So we did. Hormone therapy is too dangerous. We already talked about that. We know that that's not true. We talked about, does menopause happen overnight? No, clearly we talked about perimenopause and how we've been doing it for, 500,000 years now. That's what it feels like anyway to me. And then what about menopause means the end of sexual intimacy, which I know we'll have a podcast all about sex and the goods. But let's hit with a special guest. Yes. But does menopause means that there's no more sex?
Absolutely not.
Hope not.
No. Fix your dusty muffin.
Fix your dusty muffins, lady.
Yes, exactly. So listen, I have these amazing women who are 50, 60, 70, 80 years old who are still sexually intimate with their partner. Now, what does that mean? It could
mean that's something I can't unsee in my parents.
Right? Well, I wasn't going there. See,
I know. I'm like, oh,
that just went to a whole new level. But they're still very, very intimate. They want to be as well. So if we're, it does not mean the end of it. No, midlife and beyond is still very. Can you imagine just being like, well, you hit 60, no more sex for real?
No, because that's like in 7 years.
Now the kids are finally out, the kids are finally out of the house and all of that. So no, absolutely not. Can we make it better and less uncomfortable? If it is uncomfortable, yes, we already talked about that. Absolutely. So that's the myth.
How about I think I'm in perimenopause. I need all my lab work checked. Can we just do that really quickly?
We're gonna have a difference of opinion here.
And also, my labs are
normal.
My labs are normal, so I'm not in perimenopause. Yeah, let's just do that quickly.
Yes.
Do your lab
Because you
talk.
love them.
I love
You
data. I
love
love
them
data.
so
Do
much.
you need labs to diagnose or treat? Diagnose, yes, if you're, less than 45, then that is helpful because that tells us how much estrogen you'll need. But otherwise, we don't need labs at all. We can treat you based off your symptoms. We can adjust your meds off your symptoms. But here's what I've been finding is that women whose providers will not order any labs, they tend to find themselves going wherever they can. And they wind up doing Dutch testing, which is dried urine or dried saliva. I'm not even sure what it is because I get reports and I'm like, I don't even know what this means because I don't need those labs. I can order labs that your insurance will pay for. But patients wind up spending $500-$600 for this Dutch testing to figure out what all their hormones look like and all the precursors to the hormones, spend tons of money, or they will go and do pellet therapy because those providers will do labs. And so I find that women find labs. I do a lot of labs for them, but I know how to interpret them. And if for women, it just validates to see a low testosterone. We don't check progesterone, and we'll talk about that in another episode. But really for me, midlife carers labs are less about their hormones and more about things like their B vitamins, their ferritin, their D vitamins, looking at their risk for diabetes and looking at their cholesterol. So it's really more about wellness for me than labs, than hormone labs. And really, a lot of times, if you fix their D, you fix their ferritin, you tell them to back off on the B because everybody's taking B, whether they're low or not. Often when we fix all of those underlying issues, a lot of things just snap right into place.
Yep.
Yeah, you want to make sure you're not missing anything, that all these perimenopausal symptoms are not because you have zero iron in your body and you're so anemic or your thyroid's not functioning well, So baseline labs can be very helpful. Yeah. And also when you're down the road and someone's not responding to treatment as you think they would, it's nice to have a baseline to look back on and see, are you missing anything? Yeah.
Right. And
then sometimes you'll
absorption.
Yes. And sometimes you'll catch those really fun ones where like the estrogen's 600. I'm like, no wonder you feel like shit.
Right. And as a provider, when you see a 600, I'm going to talk to the providers. The first thing you're going to think is, oh my God, you got to stop. They're just in a double ovulation, a loop cycle.
Yeah.
It will come back down. Do not panic.
Yes.
Perimenopausal
But that's why
women will get that high.
Yes.
Yeah.
But and then the next time you check it, they're going to be tanked, but they feel terrible. So high estrogen makes you feel terrible too, guys. It's not just the low. When you're in those loop cycles, man,
that's a great
you're
point.
Just feeling nutty. Can we get them all?
How about family history? Will we make this the last one?
Let's go over that real quick. Yeah, that's important.
A lot of people feel like they are told you have a family history of breast cancer, therefore you cannot take hormones. False. There is no family history that precludes you from having hormone treatment. Let's just put that out there.
We'll put that out there. Absolutely. Could you have some genetic risk, some genetic mutations that put you at a higher risk for something? Yes. Does your does your mom having a blood clot or a breast cancer mean that you cannot be on hormone treatment? No. Does it mean that we need to maybe have a conversation about genetic testing? Maybe, or did mom have genetic testing? Maybe. Yes, those conversations need to be had, but family history is not a contraindication. Any other pearls with that?
I think it's great.
You
rocked it, Rebbecca.
Testosterone is a male hormone and women don't have any. False. Throughout our reproductive lives, our testosterone levels are between 4 and 10 times higher than our estradiol. Where we get our estradiol is from testosterone. It is then aromatized to estrogen. So again, any clinician telling you that, they learned that in medical school. They don't remember it, but ask them to go back and look at their table of steroid hormones and where they all come from, and they'll be able to see it.
Even on that one, when I was in training in the late 90s and even in my early practice, we were told not to give testosterone unless you absolutely had to, which I'm trying to remember back what that meant, but it was, concerns. From what I remember being taught it was concerns about the heart, which now we know is not true. But, a lot of people, even providers that were practicing before the WHI aren't used to giving testosterone.
I might sum everything up here for listeners.
Yeah.
So key takeaways, menopause myths can lead to confusion and fear. So understanding all of this is so helpful, can take away that fear and empower you, which is really what we're all about, isn't it? Empowering women.
Yes,
number 2, every woman's experience is different. There's no one size fits all. And which leads me on to number 3. If you're having difficulty finding help with this, find yourself a menopause specialist. A good place to start is the Menopause Society. They have a list of all of us who are certified by them. Dr. Mary Claire Haver has a list as well. Our next episode is going to be about why we have regrets on how we treated our menopausal patients in the past without any menopause knowledge or training, why we were not great menopause practitioners. So thanks everyone for listening today. We've always enjoyed going through menopause myths because they're so common, and it's nice for you to have some information to open the discussion and see whoever's feeding you the myths, just ask them a question or two and see if they can actually tell you where that came from. Thanks for tuning into the Dusty Muffins. We hope you laughed, learned, and felt a little more empowered on your menopause journey. Don't forget to subscribe, share, and leave a review to help us spread the sisterhood and strength. Got questions or topics you want us to cover? Reach out, we're here for you. Until next time, keep thriving, keep laughing, and remember, you're never alone on this wild ride. See you next time on the Dusty Muffins.